We're now going to have what we hope is a very informative and entertaining point-counterpoint on the value of extensive lab workup for all new cases of optic neuritis.
Here's my financial disclosures. 15 years ago, life was simple. When a patient came in with optic neuritis, the rule was to obtain an MRI of the brain. If it was abnormal with multiple white matter lesions, the patient was treated with steroids and possibly MS medication. If the MRI was normal, you were off the hook. The risk of MS was low, no treatment was indicated, and all you had to do was repeat the MRI in 6 months. Life is no longer simple, since we have now learned about NMO and MOG that require different treatments and often have a normal MRI. So there are now new rules. If the MRI is negative, we worry less about MS, but need the extensive lab workup listed here for diseases that require and do respond to different treatments. However, I also support doing the workup even if the MRI shows typical white matter lesions. Why, you may ask? First, we are still very early in our understanding of NMO and MOG. We were originally taught that the MRIs are all normal in the brain, but we now know that there are white matter lesions. And as time goes on, we may see more patients with more typical MS-type lesions. Second, as we follow these patients with optic neuritis down the line, and they get MS, and we tell them they have MS, they often come back a year or two later and say, "Are you sure I didn't have Lyme disease or sarcoid or something else?" And it's very useful to say, "We thought about this, we've done a thorough workup, and we haven't found those entities." It instills confidence and compliance in the patient. Third is my own anecdotal experience. Here is a patient with MS for 20 years, on interferon, doing well, who then develops a left-sided optic neuritis, shown here. She's treated as an idiopathic or MS-related optic neuritis, but ends up after steroid treatment with light perception vision. She eventually got a biopsy, and this was sarcoid optic neuropathy. Patients with immune diseases may have more than one, so we have to always consider these other entities. This next patient presented with a left-sided optic neuritis, shown here. She had 2 white matter lesions in her brain. We treated her with pulse steroids, and she went home. She developed bilateral facial paresis and cognitive changes from CNS Lyme disease, which we did not pick up early on. The third case was a patient who in 2009, a 40-year-old man, developed a unilateral optic neuritis. I met him 3 years later. At that point, he had bilateral no light perception vision and was paraplegic, and we diagnosed NMO. Wouldn't it have been nice to diagnose his NMO early on and prevent his paraplegia and his no light perception vision? In light of the above, I am in favor of this extensive workup listed here for all optic neuritis patients. My opponent, Andy Lee, can tell his patient, "I'm going to save you money." I'm going to tell my patient, "I'm going to spend a little money, but save your vision." Thank you.
Dr. Lee.
With all due respect to Dr. Moster, Dr. No is speaking now. A randomized controlled clinical trial called the Optic Neuritis Treatment Trial answered this question already. Extensive was the question. Laboratory testing is not required. Because they did it, it didn't help. They generated a bunch of false positive syphilis serologies, and they had to tell those patients, you don't have syphilis. I don't know why I ordered this test on you. So ordering tests on people without pretest likelihood of disease is not the right thing to do. However, the question of doing some testing in NLP people, extensive longitudinal enhancement, bilateral, every case that Mark showed you, you should work those up. But the regular ones, Dr. No has spoken.
I got to stand up to answer him. Without papers. Would you really not order these tests on your daughter? If this patient was your daughter or your wife or your son, and they showed up with poor vision in one or both eyes, claiming that their eye hurt on pain on eye movement, I'm not sending him to Andy Lee. I'm sending him to Mark Moster. I want to know here and now what the future prognosis is for my child. I want to know how often I have to take off work to take my child to that emergency room or to that doctor if he's available that day. I do not want to find out that I should have done differently. The workup cost, okay, brain surgery costs a lot. Working up a patient for optic neuropathy and getting a better idea on how my child is going to do, it's not a cost problem. I'm sorry.
So the no's don't have to go to the podium because we're correct. It's really great to be a closer in October because, it's baseball season. Except I'm from Los Angeles, so I really don't want to be the closer of Game 5, where there was a grand slam home run in the 10th to lose it. And not only that, it was on Yom Kippur. Like, really? But I think we all agree more than we disagree. But there's a danger in over-testing. There's a huge danger in over-testing. Those false positives, RPRs, man, go home and try to tell that to your spouse or significant other. What about chest x-rays with little ditzels that then create angst for years because they're worried, oh, could I have a lung cancer? I mean, there's a cost to testing and finding things that have no relevance at all to the disease that the patient came to you with. So the real questions are, what really helps us make a diagnosis? How do we take care of the patient? We need really clarity and simplicity. So number one, is it typical or atypical? If it's typical, the only other tests that I do a MOG and NMO now because I don't want to be wrong about that. If I make the wrong diagnosis about NMO, I haven't done the best thing for the patient. But I don't do all those other things, and it's not about cost. It's about taking care of that patient and everything about it. If it's atypical, go ahead and test, but test strategically. Don't just throw the book. We're not the internal medicine doctors or the rheumatology doctors or sometimes the neurology doctors who order hundreds of millions of dollars of tests, and who knows what's going to be positive and negative and what's going to be a little bit on the edge. Because I don't want those emails from those patients with those false positives or those on the edge positives. Oh, the ANA is a little bit positive. You've created a lot of anxiety. So test strategically based on the patient, what they come in for, and make sure that we are testing for things where treatment is different. NMO, MOG, yes, no, no, no to everything else at the outset.
Hundreds of millions of dollars for these tests?
Well,
Where do you live, California?
I can exaggerate a little bit.
No melodrama here on the no side.
And I got to tell you, in our MS center in Buffalo, we order a lot of tests because we're part of studies. I do not see a lot of false negatives for you guys to all worry about. When they occur, I call my patient. They like me. They talk to me. We explain that the test could be false positive. I've never had a big issue with a marital disagreement over a bad
I will
result.
just add, there is evidence. They went back and tested the optic neuritis patients in the optic neuritis treatment trial, and there were no NOGs and NMOs that we missed and that were diagnosed with MS. Once you have the white matter lesions of MS and the non-longitudinally enhancement, just follow the evidence, not the hyperbole.
And so one of the questions from the audience addresses that very issue. Is there room for partial testing?
Yes, but the question was extensive testing. Lynn and I are for partial testing for atypical patients, full court press. But for typical patients who have MS white matter lesions and typical optic neuritis that gets better, extensive testing is Dr. No.
As in most of these debates where you have to take a yes or no position, the answer is really in between for all of us. And clearly an absolutely typical optic neuritis, I am doing NMO and MOG at this point, just because I get one shot at the patient usually. They're coming into the ER, and I might get the sarcoid testing. But I think we're all doing this in terms of trying to figure out, in this patient, what makes the most sense. And there is variability in the entire workup in each individual patient.
Thank you very much. And so with that, please think about how you're going to answer the question again as to whether you would do extensive testing or not.